So, good afternoon, everyone. I hope that everybody enjoyed their lunch. We are in track 2, and we will be starting this session today. It's going to be about medical education and research. We have amazing speakers lined up here. So we're going to start by talking about alternatives to randomized controlled trial, which will be presented by Dr. Martin Erner from Canada. So Dr. Erner is an associate professor in Interdepartmental Division of Critical Care Medicine and the Department of Anesthesiology and Pain Medicine at the University of Toronto. He's also a staff intensivist, and he graduated from Zurich, from Switzerland. His research focuses on mechanical ventilation, extracorporeal life support, using advanced methods for causal inference on large observational data. So, welcome.
Thank you very much for the introduction, and thank you so much for allowing me to present. Somehow the slides disappeared. Oh, there we go. Okay, so alternatives to randomized controlled trials. Ideally, we would answer questions about the comparative effectiveness of treatments using randomized experiments. However, sometimes, and maybe even more than sometimes, the ideal randomized trial is not available, not feasible, very expensive, and would take a long time to answer the question. And there are so many causal questions and questions about comparative effectiveness in critical care, that it's not possible to answer these questions only with RCTs. And in this situation, when you don't have an RCT and you want to get some evidence, emulating a randomized experiment using observational data might provide an alternative way to estimate treatment effectiveness using observational data. So, first of all, we need to distinguish between association and causation. Association is not necessarily causation. Association, illustrated here on the right side, is basically you measure different risks in two disjoint subsets of the population. Conditional risk of an outcome can be observed. So basically observe the risk of mortality in patients who received ECMO and the risk of mortality in patients who did not receive ECMO. That's an association. And if you want to measure the causal effect, however, you need to measure the different risks in the entire population under the two treatment strategies. So what is the risk if everybody had been treated with, let's say, ECMO versus the risk everybody had been not treated with ECMO but only with conventional mechanical ventilation alone? And this marginal risk is usually not observed. And for this reason, in order to investigate these causal questions in RCTs and in observational studies, we need to use the counterfactual or potential outcome framework. So for each individual, one of the counterfactual outcomes, the one that corresponds to the treatment value that the patient received, is actually factual and observed. If I put Alberto Goffi on ECMO, I will be able to observe the outcome, mortality or survival, but I will never know what would have happened to Alberto if he did not receive ECMO. And it's basically a missing data problem. And in order to estimate what would have happened, I estimate population level average causal effects. And there are certain assumptions when we try to measure causal effects. The intervention we study needs to be sufficiently well defined. I have a glass of water over there, and when you ask the question, does water kill? If I drink this water, my voice is already a bit coarse, so it would be beneficial for me. It would definitely not kill me. But if I go swimming here in the sea with the strong currents and I'm submerged by the sea at the shore there, it would almost certainly kill me. So it's very crucial that the treatment is well defined and that we are aware of compound treatments with multiple versions. If you investigate whether obesity has a causal effect on outcome, then you need to kind of specify how you will create a non-obese version of the patient, or how you will make the patient obese in order to kind of measure causal effect. And that illustrates that, that obesity or also, depending on the research question, gender or sex, it's difficult to estimate the causal effect because you cannot imagine what would have happened to me if I would be a woman. This counterfactual is not well defined. There are also other assumptions, the positivity assumption. Assuming you want to investigate the effect of driving pressure on outcomes. If I'm extubated, you will not be able to measure driving pressures in me anymore. So it's impossible to have values for driving pressure in the longitudinal data, and if you just extrapolate data from mechanically ventilated patients and impute the value for a driving pressure in an extubated patient, then you will introduce bias. And then fundamentally the exchangeability assumption, treatment assignment needs to be independent of your risk of developing the outcome. And so basically, if patients of the intervention group would have received the treatment of the control group, they would have had the same risk of experiencing the outcome than patients of the control group. And that is basically what randomization does. It establishes exchangeability at baseline, and that's why randomized control trials are the best study design to compare efficacy of 2 or more interventions with minimal risk of bias. So RCTs, however, also have challenges. You can still have selection bias in RCTs, as illustrated by the Eolia trial, where you had 30% crossovers from the control group to the intervention group, and randomization only establishes exchangeability at baseline. You can have loss to follow-up. An example in critical care where this might be a problem, if you want to investigate long-term outcomes, if you look at Margaret Herrich's RECOVER study, an observational study, not an RCT, certainly not biased, but you see that patients are dropping out due to prognosis over time. And you need to account for that, because otherwise loss to follow-up will introduce a bias if you try to establish an association between the treatment and outcomes. Then RCTs also investigate highly selected patient populations because they try to maximize internal validity. You want to show the significant results and publish in New England Journal of Medicine. And by selecting a very highly selected patient population, you limit generalizability of your findings. An example here, the REST trial, published in JAMA, investigated treatment with extracorporeal carbon dioxide removal in ARDS to facilitate ultra-long protective mechanical ventilation. They screened 7,000 patients, but only included about 400 patients, which is 6% of screened patients, which kind of makes you wonder what happened, and what happened to the other patients had they received ECOR treatment. Eolia trial as well, 16% of screened patients already received VV ECMO treatment, so it's not even clear whether equipoise was actually given when they started this trial. Then sister trials, even if the design is virtually identical, you might still have different results. Example, oral rivaroxaban for symptomatic venous thromboembolism, ciprofloxacin dry powder for inhalation in non-cystic fibrosis. Identical design, very different results, probably just random variability. And finally, you might even have disagreements when you perform the analysis of the same data, but by different investigators. And that was published in JAMA. 36 they reanalyzed 36 RCTs, and in 1/3 of the reanalyses, there was disagreement in the conclusions from the original. And the most famous example in critical care is probably the EOLIA trial, where the original frequentist analysis said ECMO was not associated with mortality at 60 days, versus posterior probability of any mortality benefit with early ECMO is high, ranging between 88% to 99% in the secondary analysis of Ewan Golliger and colleagues published in JAMA. I mean, it could not be more diametral away from each other. And it's also important to know RCTs are designed and powered to answer a single causal question. So you have often sample size issues, not adequately powered, it takes a long time, and for this reason we need alternative strategies. One of these strategies is to conduct an observational study. However, what can possibly go wrong? You can have uncontrolled confounding, and this absence of uncontrolled confounding assumption is not testable. If you look here at King Charles and Ozzy Osbourne, both of them are male, born in 1948, raised in the UK, married twice, they live in a castle or a mansion, very wealthy and famous, but there is no way that you can find an intervention which turns Prince Charles into Ozzy Osbourne. I know they might be comparable in terms of certain interventions, but still it illustrates the problem. Then positivity problems in your data analysis, problems in study design, definition of time point zero, and as a result, we have examples of high-profile design and analysis failures of observational studies. I think the most famous one is probably the postmenopausal hormone therapy and the risk of coronary heart disease analysis, where initial observational studies demonstrated the lower risk in users throughout the 1980s and 1990s, and they found hazard ratios of 0.5 to 0.7, and many female patients were placed on postmenopausal hormone therapy because we thought it reduces the risk of coronary heart disease. And then they did the randomized controlled trial in the Women's Health Initiative study, and they showed it's actually harmful. And the important takeaway from that is subsequent observational studies that analyzed this association with appropriate methodology, especially focusing on time point zero and selection bias, they demonstrated that you can obtain similar findings between observational studies and RCTs, but you need to be very considerate and use a framework. And this framework is the target trial framework. I illustrate how you can use it at the example of ECMO therapy for COVID patients. During COVID, we were not so sure if we should use ECMO or not, and with the pandemic it was impossible to do an RCT, and so we tried to use data from the COVID-19 Critical Care Consortium registry led by John Fraser, 30 countries across 5 continents, and we included all adult patients admitted with suspected COVID, and compared usual care with ECMO therapy if the PF ratio drops below 80 versus conventional mechanical ventilation, and looked at hospital mortality up to 60 days. We used marginal structural models with inverse probability weighting. We first basically created clones of each patient, assigned one of the clones to the intervention strategy and one clone to the control treatment, which creates full exchangeability because clones are by design identical at baseline, and then followed the patient clones over time. And you see that patient number 2 here is adherent to the ECMO therapy treatment arm, receives ECMO and then unfortunately dies, but this same patient, the clone that was assigned to the controlled mechanical ventilation arm without ECMO, was non-adherent, and we had to censor this patient, which introduces selection bias, and we needed to adjust for this selection bias due to informative censoring using inverse probability weighting. In the primary analysis, we analyzed 7,345 patients. A total of 845 patients received ECMO during follow-up, and we demonstrated that ECMO therapy is highly effective. It's a risk difference of about 7% versus usual care with mechanical ventilation alone, a risk ratio of 0.78, and the effect estimates were similar to the Eolia trial. Now that we have this validated model, we were able to also try to answer questions that RCTs have not answered yet. So we could compare, is ECMO effective if you have hypertension or obesity? Or illustrated here on the right side, what is the right time point to initiate ECMO therapy depending on the preceding duration of mechanical ventilation. Of course, you always need to use multiple analysis approaches in order to verify that your results are actually true, that you are not just measuring random stuff. So during COVID, the group of Shahzad Chaefi and also the French group from David Ajaj, they used a very different methodology where they basically did the nested trial approach. So they considered each day of follow-up as a separate randomized controlled trial, and then compared on each day initiators versus non-initiators of ECMO therapy and pooled the results from these nested trials. And they also found lower 60-day mortality in patients who received ECMO, which increases the confidence that the estimates from multiple observational studies analyzed like RCTs actually reflect the true estimate and the true causal effect for ECMO therapy. Shirley Wang investigated in JAMA whether there is concordance between pairs of RCTs and observational studies. All these observational studies use propensity scores, so a very simple way of emulating a target trial, but they found that when design and measurements were closely emulated, there was high agreement between the findings of RCTs and observational studies. And even if you have differences between observational studies analyzed like RCTs and actual RCTs, this is an opportunity, because this will basically allow you to, using a standardized framework, to see whether is it difference in populations, difference in settings, protocol differences, and then when you analyze that, you look whether the simulations under the natural course, meaning what has been observed in the registry, whether this is similar to what has been observed in the RCT. You look at the model fit, you repeat the analysis with a different modeling strategy, and all of these findings from systematic analysis of discordant results will provide knowledge gain, because it provides you insight about the validity of study design. It will help with the identification of previously unrecognized causes, and it will tell you whether hypotheses must be rejected or refined. And this ultimately leads, and that's my last slide, to this framework. We should use the best of two works. Last slide. You have a research question. You answer the research question in a platform trials, highly controlled setting. You get an estimate for efficacy, but you also at the same time emulate trials using observational studies and get data about heterogeneity of treatment effects. You know whether there is generalizability. You investigate the effect of other outcomes, and that's how you combine the best of two worlds and how you advance and propel research that will hopefully improve outcomes for our patients. Thank you very much.
Thank you. Now we're going to move on for the second talk, which is going to be about optimizing resident experience in the ICU. a medical educator perspective. We have Dr. Alberto Goofy, who's a staff physician at St. Michael's Hospital in Toronto. He's also the Interdepartmental Division of Critical Care Medicine. He's a co-director for the Critical Care Adult Fellowship Program, and he loves traveling and teaching. So welcome.
Thank you. Okay, so we are really doing an 180 switch, is that we are going from science data to something that is very personal, and this is actually my main disclosure, is I was asked to reflect on how we can optimize the resident experience in the ICU. And what I try is that I really went back to the past 15 years of my life as an educator, and I tried to see if there is any data in the literature, but truly is that these are mostly personal observations. Okay, what is the challenge, right? Is that we work in ICU, we have a conflict. We have sick patients. We need to provide safe and timely care. And on the other hand, we work in academic centers. We have trainees, we have students, we have medical students, resident fellows, that they need learning opportunities. And they need practice, they need independence, and how we balance this, right? That is the challenge that daily we experience in ICU, is that we have two pillars of our sort of commitment, and how can we find a solution to this? So in the next 15 minutes or so, what I will try to do is that I will provide a little bit of a framework, is that how other learners, how we learn, and how can we use other learning theories in the ICU. Especially in this type of challenge, when we have a limited time and when we have sick patients to care for. Okay, how do trainees learn, right? I have two kids that are 3 and 6, and they don't want to go to school. I send them to school. They don't understand why they need to learn about geography, and they still learn geography. Cursive, oops. I still steal my slide here. Oh, perfect. But all the learners are different, right? All the learners, they have a background, they spend years already in schools, and they have different motivations. Malcolm Knowles has this 5 assumptions of adult learning. Adults, they are very self-directed. They have a past learning experience. We all come in a history. When Martin came to Toronto, he was a fully trained anesthesiologist from Zurich. He was not a 3-year-old kid starting JK. And with a significant background and experience and expertise that we had to take into account in his learning. 3 other learners, they want something that is practical, that has a huge impact on what they do on a daily basis. They are focus-oriented and they want to solve problems. And of course, compared to my kids, my daughter, she doesn't want to do the cursive and reading exercise, they have a strong motivation. They chose this as their career, and they care with patient as well, and they have a moral and ethical obligation toward the patient as well. And that's why this assumption, they have a strong impact on how we teach. First of all is that they need to have a say in what they learn. I'm not providing the curriculum without having them involved in the planning. The learning should focus on adding on what they already have, and we need to understand that. And we are going to talk at the end about this idea of precision education, right? Is that similar to precision medicine? The contact should be very practical issues. I have a patient dying of ARDS, and I have a problem in ventilating this person. And not memorizing context. It's not time anymore to memorize. My memory for that perspective is gone a long time ago. The other thing is that we talk about trainees, right? Is that but they have a different level of training. I'm still considering myself a trainee, and I'm pretty sure so Dr. Arabi is still a trainee, but definitely is in the expert category. And this is the Dreyfus and Dreyfus model, right? It's when we go from novices that they don't see the big picture. They are very analytical in the way they approach a patient with sepsis. Then we have the advanced beginner that are the most dangerous trainees, in my opinion, is because the one that have seen a little bit, but they are not yet competent. And then we have the competent trainees, and then the proficient that we are we are at the proficient stage. And that's important to take into consideration when we are teaching and we are planning curricula. And then finally is the cognitive load theory, right? I think this is extremely important, is that our brain is amazing, but is not ChatGPT in terms of ability to load data. And there is an intrinsic load that is understanding advanced statistics that is difficult. You need to understand it. You need to spend time, and you need to break the problem as Martin did, by trying to give us small pieces in his talk. And then we have the extrinsic load. And the extrinsic load is divided in what we call the extraneous load, something that is completely unrelated, but is there, is that is the setting of teaching, is the way we teach, is how boring I am in explaining to you things that are actually not pervasive to learning, and they should be reduced and avoided. And then there's the German load. That is the way we categorize the information and we put them together. Because if we are able to put in skip this, even if learning about sepsis, but if I can categorize in my previous experience, I really master the technique, I retain it, and that should be maximized. So these are three key concepts from adult learning theories and how we learn, right? You know, just all the cognitive load theory works also from my kids, that we need to keep it in our mind when we teach. And then I asked myself, I have a little bit of clear about this, but when do trainees learn in the ICU? Is that when do learn? And if you think about it, there are two big moments, right, of learning, two big opportunities. One is that the structured teaching, M&M, simulation, daily lectures, the academic half day. And those are structured events that we plan. We have a curriculum that is set, that is a priori usually planned. But then we have everything else, the just-in-time, flexible education opportunity. It's literally that like Forrest Gump, right? I don't know, but I'm in the unit. I don't know what kind of chocolate is going to come out on bed one. And that's the same, is that I don't know the patient that I'm going to deal this week, but also I don't know what kind of educational opportunities I'm going to offer to my trainees. Because of time, I will not really talk about the sort of structure fundamental, because I think there's more interesting in the other part. I just remind you two things. We love talking, but I think one of the things that I love with this conference is that they force us to stay in 20 minutes. There is a Lancet study in 1978 showing us that the peak of attention is at 15 minutes. After 15 minutes, people, they stop listening to you. Okay? No more than 30 minutes talk. Let's try to avoid long teaching sessions. They will not learn much from this. The other thing is PowerPoint. I used to love PowerPoint when I was early career. And I felt that I could use cool transitions, animation. I was really carving those slides. And then I realized that they were overwhelming and they were very rigid in a certain way in terms of what I was teaching. And so more recently, I actually doing most of my talks in the ICU on a whiteboard. The chalk talk are extremely impactful. You need to master the knowledge. You need to really know what you're doing. but they have an extreme power for me. And I think is that I strongly recommend you reconsider the chalk talk and do a little bit less PowerPoint. What about this just-in-time facilitated activities? So Dominique Piquet is one of the intensivists in Toronto at Sunnybrook, and she did an incredible study a few years ago when she observed hundreds of hours of interaction in the ICU. She really spent days and nights in the ICU. And what she realized is that there are two key frameworks when we teach. One is usually what happens in multidisciplinary rounds, or the morning rounds, where she sort of codified this like a serious model, where you do patient care, you discuss with the nurses and the RTs and the residents, and then you take a pause at the bedside, you do some teaching, and then you go back on the patient care. If you think about it, that's usually what happens, at least in Toronto, in most of the units during rounds. But then there are the medical crises, situation where we are resuscitating a patient, where we don't even know what's happening with this patient. We have no idea if the patient has endocarditis, cardiogenic shock, and we are really busy with the patient. And so in these situations, you cannot really pause, teach, and then go back and resuscitate the patient. You need to be in a parallel mode where you have these learning flashes, where as you are teaching, you do a little bit of a simple teaching, and then you go back. And those are as powerful and as effective in learning than those more learning bubble situation. The problem is that we don't have a lot of time. And so we need to find strategies to teach effectively, even when a patient is arresting. I found actually I didn't put the reference here, but I found this article that it was sort of, and I completely agree, is that in these scenarios, I know that we want, like a conference, I want to give you everything, okay? We were just talking with Tom this morning now, the fact that he started his talk with 60 slides, and then say, okay, I need to go down, otherwise no one is going to really at the end bring anything home. It's the same here, is that teach what is needed, okay? And that's when it comes, know your trainee, identify the learning of the trainee, even in the context of such a crisis, limit the teaching to what they need, what not you want to show off, and then provide feedback. And we will talk at the end quickly about feedback. There are a few techniques described in the literature. One is the 1 minute preceptor technique. That is really is giving you steps on how to engage the trainee and make them this a reflective opportunity. If you Google 1 minute preceptor technique, you can find examples. They are very effective, and I think I've changed a lot of my practice by using this technique. But then there is the Slumdog concept. I don't know if you remember the Slumdog Millionaire, the movie that won the Oscar a few years ago, where there was this, hopefully the audio works. Yeah, it works.
What the hell can a Slumdog possibly know?
So in this movie, this kid wins the Who Wants to Be Millionaire show by having very poor education, but knowing the answer to the question from real life experiences. And it's a beautiful movie, and I really think it really stayed in my mind. And I found an article sort of discussing about this idea of Slumdog concept, when life gives the answers. And there was a quote in this article saying, don't memorize, make memories. And again, think about my personal experience. I still remember June 5th, 2022. I was in a resuscitation room with Tom, and we discovered that by pushing the belly in a patient, the plateau pressure was going down. And I will never forget that situation. And I understood a lot of things about overdistension in a way that 6 hours on the board, I would never really, one, remember, and two, get so engaged. In ICU, we learn skills. Don't forget that we need to first show how we do a skill. We need to have our trainee practice before they become automatism, okay? And we have this in North America, see one, do one, teach one model, right? I think there are some values in the C1, but I think I try to change it here. There is called this activate demonstration model, where it's extremely important when you're showing a demonstration at the beginning, you need to activate the learners by providing already active feedback and learning opportunity in the way when they are observing. And then supervise. We cannot pretend people to learn if we don't supervise them. And that's the tension between supervision and independence, right? I've been using more and more to offload a little bit the demonstration part, videos. There's a lot of excellent resources. Pretty sure you are familiar with the New England Journal images series, video series. They're great, and they really give us an excellent opportunity to reduce, again, that time that sometimes we miss in ICU, but then you need to be at the bedside. How many minutes I have? Okay, 3 minutes. What we don't teach or do well enough. I don't know if have you ever seen this TV show, Scrubs? This is episode 1, series 1, when they start their residency. First call Blue. Oops. The video is having a problem. They call a call Blue, and he runs to the code, and then he realizes, wait a second, is that I don't think I can run the code, and he hides in the closet. Okay? And that's called stress, right? That's called stress, and I'm pretty sure that we all experience this, is that when facing an event that we perceive as stressful, this person is dying, and I'm supposed to run the code. And that's in this cognitive appraisal theory of stress, is that's the first question, the first event that happened. Okay, this is stressful for me. And then the second part, do I have the resources to manage this stressful event? And if the answer is yes, that's become a positive challenge, okay? As I get older, I'm less stressed and I'm more excited about cool cases in the ICU, challenging cases. But if I don't have that resources to manage for multiple reasons, that's a negative threat. And negative threats are associated with problem with memory. Think about the fact that in a stressful situation, you can even, for me, I can't speak English. I revert back to Italian when I'm very stressed. I cannot focus on what matters. I cannot remember the 4T's and 4H of ACLS. I have my own timer, 3 minutes left. I become so focused that if the focus on my resuscitation is beneficial because I'm the one putting the airway, that's great. But if the stress is peripheral, someone screaming or a very emotional situation, I get distracted. All things that are all related to catecholamine and cortisol release. And then the other thing is that it's memory. I'm pretty sure that you all remember vividly stressful cases in your life. The problem is that not necessarily you remember the teaching point of them. And all comes down to what was the most stressful or loud stimulus in that stressful event. If it was the family member screaming, you will remember the family member screaming. You will not remember the learning opportunity. And this is all coming to neurobiology. The other thing that we don't teach enough, to me, is what we call critical thinking. Okay? Because this thinking is, the critical thinking is that type of thinking, we question, analyze, and interpret, and make judgment about our thinking. It's metacognition. Okay? And that's extremely important, is the questioning ourselves. Why this is important? Well, because our perception is flawed. Okay, I'm going to do a quick experiment with you guys. So I'm going to show you 3 cards. 3 simple cards, okay? Spade, diamonds, and I want you to remember them. Okay? Ready? 1, 2, 3. So what did you see? So with a jack of hearts? You sure? Jack of hearts is actually a jack of spades. But what's the problem here is that it's a red spade. Okay, let's do another experiment. What do you read here? A bird in the bush, right?
20 seconds.
It's actually a bird in the bush, okay? Because that's what we do. Our brains bend our perception of reality to meet our desire of expectations. And what we do, we fill the gaps with what we want to see or with our past experiences. These are called cognitive biases. There are more than 100 described in the literature, and I strongly recommend you to read this article where describe the 6 of them that are most commonly associated with our job in critical care. And we need to be aware of this, because if we are not aware of our own biases, we will go in a difficult path. We need to acknowledge uncertainty. The worst thing that teacher can do is not to show the trainees that himself or herself are uncertain when it comes to difficult cases. And when we ask questions to our trainees, we should not ask us, okay, what's the dose of Levophed? I don't care about the dose of Levophed. Is that how and why? Why do you want to start Levophed? And how do you think that Levophed is going to help norepinephrine in the care of this patient? Those are the important questions that they force them to use critical thinking.
We're over time.
And I'm finishing here. 2, 1, 2, don't be afraid of acknowledging failure, and don't forget about our respiratory therapists, pharmacists, nurses. They are incredible teachers, and I think it's extremely important for them. I'm going to stop here for time, because talking about failure in teaching, I overestimated my ability to go through all the slides. Thanks.
Thank you so much. We can get to the part of the questions toward the end of the session. Thank you.
Thank you. Now we would like to call our next speaker is the chairman of the Intensive Care Department, Medical Director, Respiratory Services, Professor, College of Medicine, King Saud bin Abdul Aziz University for Health Science, and King Abdullah International Medical Research Center, King Abdul Aziz Medical City, Riyadh, Kingdom of Saudi Arabia. Dr. Arabi leadership has been recognized in multi-awards, including the Saudi University's Excellency Award in the scientific productivity, and had well-established critical care trials regionally and globally. Please welcome Professor Yasin Arabi.
Looks like we're having a little bit of a technology issue here.
Yes.
Okay, maybe we can take one question from the audience while they set up the presentation, if it's not ready. Are there any questions for the previous 2 speakers about the alternative of clinical trial? Okay, can we get a mic here, please?
question is for Dr. Alberto. Thank you for your presentation. I would like to ask how to deal with a difficult learner.
Can you repeat your question?
How to deal with a difficult learner.
With a difficult learner. Okay.
So it's a very difficult question. In a sense, it's a difficult learner, difficult question, right? Is that I think is that, and again, I'm going mostly by experience and not by literature. There is a little bit of on this, and it comes down to, especially when it comes to medicine residents. Okay, so we are talking about people that they went through years of education. They were highly selected. If they're difficult, understand the why. And again, the story behind failure, a difficult interaction, something is telling you that there's something, at least in my experience, that we are not aware. So before labeling someone, the halo effect, or is a difficult learner, is a pain in the ass, is that is someone that is always causing trouble, I think is, I still haven't found in my career a difficult learner. I found a learner that is experiencing challenges, and again, as educators, it's our job to try to dissect the problem and find solution together. And that's when the feedback, that was my last slide, becomes extremely important, right? Is that where having an open, honest, direct, and timely discussion may help understanding what happened. It's never judgmental. It's always about we observe this, and it's never about the individual, but it's what happened and what you think is happening, what's happening. Because again, is that I'm pretty sure that at a certain point in my career, I was a difficult learner because I pissed off someone. But was I a difficult learner, or was the relationship that was not working, or what was offered to me that it was not answering my needs? I don't know.
Okay, fantastic. Thank you for the question. I think we can resume now the presentation.
Slides are changing here, but not projecting.
Would you like us to take another questions, or is it sorted? Is it sorted?
Not yet.
Not yet. Okay. So how about we take a second question? If there are any questions.
I want to ask you about how to teach soft skills, how to teach residents human aspects. I think that's one of the challenges really in education, because we are moving a lot of technology and
Can you have a mic here, please? Yeah, you can.
So the question was is that in terms of skills that are required for a doctor, there are a lot of cognitive skills, that there are procedural skills, but there's also the teamwork, communication, right? Those are the skills that you're saying, is that how to be an empathetic person. Yeah. Well, the interesting thing is that people, they tend to feel, oh, these are things that are already you have it or you're not going to learn. Actually, there are some data that you can teach them. They can learn them. Requires, again, understanding on where the person is coming from. Is usually is experiential. Comes from, for example, the slides about the interprofessional team, right? Is that those are extremely powerful situation. Is that simulation, where you focus, we tend to focus simulation on skill and knowledge, but there's a lot of, especially when you do multi-professional simulation, there's a lot of potential for communication, dealing with difficult families. And those are powerful situations to learn. In our hospital, we had this sort of TRACE Academy, we call it. There is a high-performing team training, where the idea was really is that how can we be a better team together? And to me, the best and most important intervention that was done in the TRACE Academy was that we had family and former patients coming to teach us. And hearing the perspective of a family on how was the interaction during rounds, it was extremely powerful. Those are things that they really touch your soul, and the next time you go back to the unit, you're going to remember this, even if you are not much empathetic.
Thank you so much. I think we can start.
Thank you very much, and sorry for this technical issue. So we learned again and again over the last two, or actually workshop as well, that randomized controlled trials are the way to go. We should be randomizing patients. Some patient will get this, some other patient will get the control group, and we can compare them. And we also heard that there are alternatives to ways of looking at evidence, and sometimes individual patient randomization may be difficult or impractical. And I'm going to try to show you an example of the SCREEN trial. This is a trial of sepsis screening where we use a different approach, where we use electronic medical records in a different study design. There are lots of things to learn from this, but I was invited to talk about the use of electronic medical records from the study. Now, for sepsis, we know that early intervention makes a difference. And based on this, clinical practice guidelines recommended that hospitals should have programs for early identification of sepsis. So this is a system-based intervention. You are trying to do system-based intervention. And for system-based interventions, randomization on an individual patient is really hard. You need to do system-level randomization. And most of the studies that exist in the literature are observational. Like the systematic review looked at almost all of these are observational studies, showed that implementing electronic sepsis alerts was associated with reduction in mortality and was associated with improvement in the bundle of care. Patient got fluid earlier, got antibiotics earlier, got lactate more often, etc. And our journey with implementing sepsis alert started in 2011, where we implemented electronic system in our electronic medical records, where alert comes up when the patient met SIRS criteria, because that's what was there in the literature. And by implementing this, actually the compliance with the bundle, sepsis bundle, improved in the upper panel from around 20% to 50%. Then in phase 2, we had the sepsis team that improved it to 80%. And with this, the mortality reduced from 50 to 20, almost 17%. The issue with this type of intervention that you denominator change. When you start to screen, you pick up a lot of milder cases. So you don't know if you're actually making difference or you're just diluting your sample with milder cases. So even with the adjustment, we saw a difference, but I think the confounding effect probably still there. And interestingly, this systematic review looked at randomized controlled trials of having electronic alerts for sepsis or other things versus observational studies. And what's interesting is that observational studies showed a difference, while randomized controlled trials were kind of neutral. But keeping in mind that the randomized controlled trials were small size. And also one concern about implementing sepsis screening. If you start to screen and label the screen as sepsis, you may end up giving more antibiotics. Maybe that will increase MDROs and C. diff. So there are pro and con for implementing sepsis systems. And for that reason, we designed a clinical trial addressing whether electronic alert system compared to no screening reduces mortality in patients on the wards. Now, you could imagine this is not an easy study to do. You cannot do it individual patient randomization, just not possible. This study was done in 5 hospitals in Saudi Arabia, and eventually in 45 wards, which is very large. And we had a protocol and statistical plan published. The unit of this study, which is a step-wise randomized control trial, the unit of randomization was wards, not patients. So wards were randomized. So we included wards that are medical, surgical, or oncology, and we did not include cardiology or any monitored wards. So mainly the usual adult medical surgical wards. So typically in our hospital, probably like in many, many other hospitals, respiratory rate and blood pressure are entered to EMR every 4 hours and GCS every 12 hours. And we create a system using QSOFA. If the patient within 12-hour window met 2 of these criteria, then electronic alert appears in the system. And for purposes of the study, the electronic system was designed to be either concealed or silent mode, so it will be in the background of the electronic medical record, or revealed mode where the treating team will be able to see it. And that's an intention, so we can have some comparison in process of care. So if it's revealed, so if it's activated in certain wards, then an alert appears to the nurse to ask her to assess the patient and notify the physician. The physician will get an alert. Also, the charge nurse will get a notification on a mobile device with the audible and visual alarm. So almost instantaneously, somebody will learn that this patient met the criteria. And the data also are fed in a dashboard that is used to give reports every month. So there's a lot of activity to try to improve the compliance. There was a lot of education. And the whole idea when we did all the education, that we are really interested in getting people assess the patient. The alert by itself doesn't treat. Is what matters is this is alert for you to know that your patient is sick and assess the patient. And based on the assessment, patient may or may not need different treatments. This was independently for completely unrelated reason was assessed by the HIMSS, which is the Healthcare Information and Management System Society, part of the accreditation for EMR, and was part of our Stage 7 accreditation, and also part of the Stage 7 Infram accreditation for the infrastructure. And they had a very nice article on their website about our sepsis system. It received also national recognition for patient safety in Saudi Arabia. So here we have 45 wards. And these 45 wards will be randomized to 9 groups, 9 sequences, okay? And each ward is called cluster. We're going to call them wards. And we randomize them using concealed approach, so the wards don't know that they're going to be part of the implementation until 1 month before implementation, so we can do education and then it will be implemented. So the intervention meant that the wards that will be activated will have the system turned to the revealed mode, training will be done, and feedback about the compliance will start. When we activate the alert in certain wards, it's a ward level activation. So at 8 o'clock in the morning, February 1st, the system will be turned on at 8 o'clock. So that meant that everybody is admitted to that ward from 8 o'clock onwards would have the system activated. But also it meant that the patients who exist at that time and carried over from the previous time will also have the system activated. That led to some contamination that appears in the results and need to understand it. So some of the patients from the control group would have system activated for them. Also in a hospital, a big hospital like ours and yours, patients are transferred from one ward to the other. And this is not in my control. So there are patients who are in the control group would be transferred to the other and vice versa. So there's, again, you will see some degree of contamination, not a lot, but it explains why this contamination happened. So here are the 45 wards. They will be in 9 groups. And in the first 2 months, we did this in 2 months periods. The first 2 months, everybody in the control group, This is what the step wedge randomized trial is. So step wedge, all of them in the control group, will just see what happened to these patients. 2 months later, the first 5 wards will start to have the active screening. 2 months later, we'll add the other 5 wards, add 5 wards, add 5 wards, 5 wards, 5 wards, 5 wards, 5 wards, and then we're finished. And what you could see here immediately, that these 2 groups are not necessarily similar, really. So this is by design. This is what the step wedge randomized trial is. So period 1, all the patients in period 1 are in the control group. And all patients in period 10 are in the active ward, okay, in the active group. Similarly, everybody in sequence 1, or a lot of patients sequence 1, are in the control group. So these wards will have the system activated early, while sequence 9 will have it activated late. So most of their patients will be in the control group. This meant, and that when you read the studies, you need to know that you cannot look at crude values. They will not help you. You need to look at adjusted. We have to adjust for the wards, and you have to adjust for periods. So the study started in October 2019. And you could imagine this is a lot of work to get this started. October 19, 1st of October, the study starts. And now the first 2 months, very easy, because control group, don't have to do much, so that's nice. December, the first 5 wards are included, also not very bad, you can do it. Then March, will be February 2020. The next 5 wards are added. Again, not a big deal, except COVID. Then COVID came. And COVID has influenced hospitals big time. And we started what we're going to do. Now, big pandemic everywhere. Surgical cases are canceled. Some electives are all not coming. Number of admissions reduced. But it's really hard to go back. I mean, you cannot just undo things. It's really not practical. So we decided we're going to push through. So the rest of the study, we had to live through COVID-19. And COVID-19 meant this shaded area, you will have sicker patients than the first 2 groups. And the implication for this, we have to do adjustment. You have to adjust for COVID-19 as well, okay? The risk of death from patient admitted to hospital with COVID-19 is very different. I'm going to show you this. Very different from the non-COVID-19. So to understand what are these adjustments for. So COVID-19 had multiple implications. Certain wards were converted to ICUs. Then during that period, we have to remove them. And we have to extend a couple of the periods to 3 months because of slow enrollment or slow admissions. Now, this study is based on electronic medical record alerting, based on dashboards, all electronic, but also based on extracting all the data from the electronic medical records. There was no manual data collection. There's no manual data collection in this. So all the data was collected from electronic medical records. And I thought it's going to be very easy. When I started the study, I thought, oh, that's a piece of cake. But no, it's really hard. And it requires substantial amount of data management. And you'll end up with a very big amount of data. So sample size calculated to be 65,000. And if it wasn't using electronic medical records, this would have been impossible, okay? Statistical analysis, the short story here is you need to look at adjusted analysis for adjusting for periods, for wards, for hospital, and for COVID-19 for the reasons I just mentioned. So in brief here, we have 84 wards were screened, ended up with 45 wards randomized, and this is the number of patients were included, around 60,000 patients. This is the distribution of patients in the all periods and sequences. So median age is 59, similar in the 2 groups. The 2 groups were generally similar except for the COVID-19. COVID-19 really caused some imbalance because of the graph I showed you. More patients in the intervention group. So in the screening group, there were 11, almost 12% patients with COVID versus 5% in the no screening group. So in the 30,000 patients in each group, there were around 4,000 to 5,000 patients who had alert. So in the screening group, these are the active alerts, the visible alerts, and the no screening group, these were the silent alerts. And in the screening group, 74% of the alerts were acknowledged by physician and by nurses, and 1/3 of them were judged by the doctor to be sepsis, because one of the question asks you when you get this pop-up message, do you think the patient has sepsis? You have to say yes or no to close the alert. The difference in alerts were, again, COVID-19, more in the screening group than non-screening group. And what happened with the management of these patients? These are the process of care. Again, all this from electronic medical record, showing that there was increase in the bundle of care. There was increase in measuring lactate, intravenous fluid, blood cultures, respiratory cultures, and antibiotics, especially during the stay, because it's repetitive. Sometimes it's not the first alert, but some patients got multiple alerts with time. It's interesting to see how the Q-SOFA was associated with mortality. In patients who had Q-SOFA, had 9-fold increased risk of death compared to have no SOFA. We're talking about patients on the wards, okay? So patients on the wards who have a Q-SOFA positive, they have mortality of 12%. That's probably similar to ICU patients, right? Maybe higher than ICU mortality, versus 1.5% for those who have no alert. So it really was very good in differentiating patients at risk for death versus those who are not in risk for death. So the primary outcome, again, if we focus only on the adjusted mortality, I could talk about all these issues, but the adjusted mortality relative risk is 0.85, so that's with the confidence interval 0.77 to 0.93, so about 15% relative risk reduction in mortality for hospital wards. That's not small. That's when we talk about system-wide implementation, that's a good reduction in mortality. If you divide or stratify it by periods, there was consistent reduction in mortality across all the periods. The baseline mortality changed in periods because of the peaks, but the reduction in mortality was consistent throughout. Now, how does we translate this to simple language? It translates that the number needed to screen was 206. You have to screen 206 patients to save one life. 206 patients in our hospital are expected to have, 3% mortality means 6 will die. So 6 would have died, one of them would be saved by this system. 1 out of 6 death. That's very good, for alert system. That's really actually remarkable. These are the secondary endpoints, and the sensitivity analyses were consistent. We did multiple sensitivity analyses, all consistent with the primary outcome. Subgroups showed consistent reduction in mortality, whether patients were less than 65 or more, whether the admission was medical, surgical, oncology had more impact than the others, or COVID-19 versus no COVID-19. And here you look at the baseline mortality for COVID-19 is 9.6%. Compared to non-COVID is 2.8. If we didn't have COVID, we would have results similar to the lower one, 2.5 versus 2.8.
2 minutes.
Almost finished. So the main finding is electronic screening sepsis in hospitalized patients reduce mortality. Relate to the use of electronic medical records. This would have been possible only if we did this electronically, with implementation of the intervention, data collection, and giving feedback. It's all through the electronic medical records, but it required really massive collaboration among hospital staff and leadership. The CEO led many of our sepsis awareness days that we have it yearly, and you could see interaction with the front line about sepsis and sepsis alert, etc. Sepsis, we need to work on sepsis in all our hospitals to improve the outcome, and there's a lot of things to do, but the interaction has been amazing with the medical, with the IT, with the quality management and research and nursing. Long list of people, 5 hospitals, 45 wards. That was a really big thing. This was published in JAMA, so please feel free to look at it, and this is a visual abstract. And thank you very much.
Thank you, Dr. Arabi. I congratulate you on this amazing study, because as a chair of the mortality committee in Emiria Hospital, and the whole digital transformation that's been occurring in our hospital, it's beautifully demonstrated how simple intervention in the digital system can actually reflect into improving patient care and reducing mortality. So I congratulate you for the study.
Thank you. Now we would like to call our last speaker. She is a professor of nursing, dean and head of school at the School of Nursing, Midwifery and Health Systems, University College, Dublin, Ireland. She is the editor-in-chief of the Public Health Nursing Journal and associate editor at the Journal of Advanced Nursing. She is a competent researcher who has led severe interdisciplinary international research teams over a 25 years period. She has published numerous papers with 255 peer-reviewed papers listed in Scopes. Please welcome Professor Dr. Fiona Timmins.
Thank you.
Thank you very much.
Maybe, yeah.
Is it working? Yes,
Yeah,
thank you.
yeah, you can hear yourself.
Thank you, just turn it on, apologies. So Eve, everybody, Dias Eve, Fáilte, Tá Anna Orsarum, Gwilmi, Stocksanach, on Tír Seo. So I'm speaking my own Irish language. I'm from Ireland, and I'm very pleased to be here at this conference, and I would like to extend a huge thank you to Dr. Ali and all of the organising scientific committee for firstly organising such an incredible conference, extending the invitation, and just allowing us to become excited in the sharing of knowledge and generation of future knowledge and research. So thank you firstly for that. I would like to secondly make a huge thanks in terms of our welcome and the facilitation of our comfort, and also indeed our learning. How many came to the museum last night with us with a beautiful time and the bus? It was wonderful. And we were reminded in that really excellent presentation about the human quest for knowledge and to learn. And not only that, but actually to document that learning as well. And we saw the fine Arabic scholars, referring back to the Greek scholars, ancient tradition of exploring, researching, scholasticism, writing that down, passing it on, and as my colleagues before me have presented, this idea of then replicating these and researching and improving and developing and advancing as humankind in science, medicine, technology. And as many of you will know, how many of you are nurses in the audience? Just physicians, doctors? Thank you, colleagues. Dietitians, physiotherapists, intensivists, speech and language therapists, researchers. This gentleman, oh, in the blue. Pardon? Dentist. Intensivist. Welcome. Thank you so much for your kind support. Many of, I don't know how familiar you are with the nursing literature, and this is what I'm focusing on today, but the nursing scholasticism and the scholastic nature of nursing, or the sort of writing down of any advancement of nursing science and nursing theories and nursing practice, is really very, very new kid on the block compared to the ancient sciences that we understood last night, and indeed even the ancient science of medicine, which has been informed by many of these prior sciences. So what encouraged us as nurses to start to speak and write? And indeed, actually, I mentioned at a previous presentation, I'm a third-generation nurse. My grandmother worked in the 1930s in Ireland. My aunt was an ICU nurse in the 1970s and 80s in Toronto, St. Michael's Hospital, and Dr. Irmer is from that place. And indeed, when my grandmother trained, don't mean to run down my own profession, but you just needed to be able to read and write. That was where it was in 1930s. And essentially, the whole idea of advancing came from very much within the nursing profession itself, because we have always had this dedication to, and we're an ancient profession. I'm just saying that the actual scholasticism and the advancing the written and the becoming together as a discipline is relatively new, really since the late 1800s. Nurses within the discipline wanted to be organized, they wanted standards, they wanted regulation that came internally from the profession, and that heralded the professionalizing agenda in nursing. Alongside that, for various reasons, came the academic component of that professionalizing agenda. It was to do with science and technology and the advancements and the advancements needed in our own knowledge and awareness, but also, again, a movement within the profession too. So essentially, the whole professionalizing agenda, largely speaking in the last 100 years, has seen an increase in the nurse's voice, we'll say, or the nursing research within the actual published literature. So for me, the first ever nursing publication coming from the Republic of Ireland was in 1974, Bridget Tierney, and she was doing what maybe my colleagues, Dr. Ali and others can do now, is just telling the world what's going on in Ireland. She said there was 1 million souls in Ireland, that's people, and that she outlined the infrastructure of nursing, and there was a lot to do. You know, that there was just a teacher's course, random sort of certificates for nurses, but we'd a long way to go, and it would come in the future. So this visionary kind of writing. 20 years later, in 1994, things were the exact same. I went to university, loved libraries, like many of you love libraries, and saw all my medical colleagues and colleagues from the intensivists and physicians, dietitians, physiotherapists, writing and publishing and researching. And I was despaired by the absence of the nurse's voice in the literature. At that time in Ireland, 1994, there were 15 publications from Irish scholars. And now that number, 30 years later, is up in the thousands. So basically that voice, I've been very passionate about encouraging the nursing voice, encouraging the dissemination of the research, not only research, but your practice, and also the ideas and thoughts that one has. So today I'm going to speak very briefly about this in relation to Kuwait. So I'd like to explore publication outputs from Kuwait in the field of ICU nursing, and to further explore the broad contribution of Kuwait within the nursing journals, to identify some patterns and trends very briefly, and then to explore mechanisms for the future in relation to disseminating evidence from Kuwait, ICU research in particular, but also in relation to innovation and practice globally. And as I mentioned, my colleague Bridget in 1974, one very important thing about getting your voice out there, and we were talking over coffee, I lectured Dr. Ali for about an hour about publication, is putting a mark in the ground as well and saying this is where Kuwaiti is in 2024, so that you can look back. It's a historical pinpoint. So Bridget, 1974, she's in the literature. We can see where Ireland was then, and we can see where we are in the future. So it's important to be on the map, I guess, in a way, which is very, very important. It's important to say as well in relation to the scholarship of nursing and the advancement of nursing as a discipline, as a science, as a profession, it's happening in different parts of the world at different times. Even though the practice of nursing can be quite uniform in ways, the United States were the first to have graduate nursing, which was started in the early 1920s and even before, and then other countries like France catching up only very recently. So there's variations in this, and this causes problems for the sharing of our information, because what is new in Kuwait in terms of advancing nursing practice is not new in the United States. So we have a difficulty. Second challenge is the homogeny of the English language. Many of you know in the room that the science very often occupies a sort of an English space, and it isn't always straightforward to become published if English is not your first language, or if there's a certain homogeny in relation to that. So many of you will know the whole idea of dissemination then is through global publication. The whole idea why it's so important for nursing is it publicizes and raises the profile of important activity, what you're doing in your ICU, what you're doing in Kuwait, what you're doing in various places. It shares important activity and findings with the relevant community, and it permits an open dialogue and debate about activities. It enables research to have impact, measured by citation or altmetrics, and it serves to raise the profile of the organisation and profession. And of less interest to those in the room here, but in university, it's very important in promotion, employment, and ranking system. So it can be very important for the future of you as a discipline. So in terms of just having a little look-see at what's happening in Kuwaiti nursing, databases such as Scopus and Clarivate can be an important resource for really just drilling down to look at the impact and extent of research activity of individuals and groups. So I did a search in Scopus in 2025 in January, looking at the extent of publications from Kuwait in the field of nursing in general, and then specifically in the following journals: Nursing in Critical Care, Intensive and Critical Care Nursing, and the Journal of Advanced Nursing. So I can show you on this slide here the annual trends. As you can see, I mentioned to you Ireland in 1974, maybe in a very similar situation, not too much. But in Kuwait, we're expanding slowly, slowly, slowly. And overall, what I can say to you is there are 635 registered papers identified as nursing within the global published database. If we see where do these come from, Kuwait University, Ministry of Health, and so on. What type of articles are your nurses publishing, or are those who are publishing in nursing putting forward? Generally speaking, they're called articles, which refers to research publications, similar to my colleague, Professor Arabi, original research. Very small numbers of literature reviews or synthesizing the literature in a systematic way. Very small numbers of editorials and letters to the editors, which my medical colleagues will be very familiar with from their own work. The countries then, who are you engaging with? Yourselves, which is understandable, other areas of the Middle East, Egypt, Canada, Australia. So a little bit of international collaboration, but we can see from the big box there that generally speaking, we're working with ourselves in terms of Kuwait. Who are the main authors then? These are the titles here of the people who are mostly writing in terms of the top 10. And I'm going to briefly talk about the top 5 and just see what type of trends. Just an example to say to you about nursing journals. This is the way we are ranked from a university perspective. This is the group. But they tend to include nutrition and various other types of journals that have been categorized under nursing. So we're getting kudos from groups that we're not researching with. But just to note that sometimes when we're looking, and you'll see now in a moment, that much of the research that's coming from Kuwait is in and around the nutrition and the nutritionists rather than the nurses themselves. So just an idea of some of the papers, give you a flavor of the nursing publications. We're talking about artificial intelligence, which is fantastic. We're talking about being a good nurse in COVID. That's our own Professor Anne Gallagher and our own Dr. Ali. Well done, congratulations. And diabetes, diet, and so on, which are important topics. Vaccination, COVID, and so on. So we're seeing. So in terms of our top authors, who are they? What are they doing? Essentially, they're mostly from the medical profession. Nursing professors and nurses are not represented in the top 5 authors. This is not unusual. We would have similar situations in the United Arab Emirates. We'd have similar in other countries such as Greece, Poland. I mean, where the nursing profession hasn't really made a huge footprint in the published literature, this is a standard trend. It would not be the case in the United States of America and not the case in the United Kingdom, where generally speaking, these top 5 would be nurses, professors in nursing. So we have, the first person, Al Musa there, high H index 28. The second person is Finnish, very high H index 217. Huge number of publications, statistics, medical, and so on. So a closer look at these individuals, just at their recent output to see what sort of things they're writing about. The Finnish person that I mentioned there, it's all about the diabetes, a huge diabetic study in Finland. The pressure injuries. Professor Musa talking about obesity, ALSA, overweight, obesity. So current topics that are very important in this culture. So the trends in all nursing publications listed in Scopus, there's been 600 odd publications ever And that's, I actually don't know the figure of how many publications there have been in nursing in general, but it is certainly in the thousands and probably millions. So overall, there's been a slow but steady increase year by year in publications categorized as nursing from Kuwait, since 2009 especially, but mostly over the last 5 years, which is a very positive thing. The majority of published papers are categorized as research, and this is a very important finding given the importance of research and scholarly output in relation to the professional development of nursing as an academic discipline. And it's interesting to note that although categorized as nursing, the most common titles found in this study did not feature high-ranking nursing journals. And a closer examination of the trends also revealed that the top 5 authors, that is those that most frequently published in nursing categorized journals, did not appear to be affiliated with nursing colleges or schools. So let's have a little peep at the journals. A very prolific journal in relation to ICU is the Intensive and Critical Care Nursing Journal. Unfortunately, there have been no papers at all published from Kuwait during this period. Since it started, this journal has published 2,400 papers, so none from Kuwait. The Nursing and Critical Care Journal, 1. In this period, in its whole lifetime, it's published just over 2,000. And this is a study of nurses' perception of their role in extracorporeal membrane oxygenation, a qualitative assessment. Professor Muna. We'll come back to that person now in a moment. So, College of Nursing, assistant professor, H-index of 3 and 7 publications. Singular author in the field of nursing and critical care. So I would like to just, I think, highlight and congratulate Professor Muna as a trailblazer, and indeed I met many of our colleagues, Dr. Ali included, Dr. Hannah Safra, Dr. Henan, and Dr. Amma yesterday. There really is a great energy and excitement and impetus, a bit like our forefathers and mothers in nursing that led this professionalization agenda in Europe, in Britain. You are there, those trailblazers are actually there. To have a footprint like that in the literature with the resources that you have and with the barriers that are there in relation to the advancement of science in a world that is already very advanced, I think I really have to say this is important to acknowledge that there are some really, really good people making a footprint in the literature. Other areas that Professor Muna, Dr. Muna has looked at, very good that we're picking sort of, up-to-date topics like artificial intelligence, lessons learned in terms of Kuwait, learning styles of students. Worth noting that the nursing profession has a particular interest in education and is developing a very strong scholastic input in that area. So that's something that we're proud of, and we see that this is reflected too in Dr. Muna's work. I like as well the whole idea of culturally contextual research, which is very important when sharing with the remainder of the global world. Very nice paper here on a virtual training center. Just finally, a quick peek at the Journal of Advanced Nursing. In its lifetime, it's nearly 15,000 papers, and unfortunately, there has only been 6 from Kuwait. So we need to change that, starting with today. Professor Ali's going to go home now and start working on an editorial. He'll have it for me by next week, isn't that right? So we agreed that over coffee. And let's have a little look. Now, the disappointing thing about this is they're a little bit old. It's 1991, AIDS patients, pain, palliative care. 2007 was the last publication. So this is analysis of the trends in the Journal of Advanced Nursing during that period. It's been a bit up and down, and not too much really in the last almost 20 years. The top authors published during this period, Al-Kandari, that's the same person actually, and just a message coming out of this for all novel scholars: register with an ORCID ID, consolidate your records if your names are being displayed differently, and make sure you're getting the credit for the work that you're doing. So that's the same author, and then we have a couple of others that I'll look at very briefly, just individually, a little bit closer. Al-Kandari is a professor at Public Health Authority in Kuwait. Professor Hashim is General Practice Epidemiology. Dr. Habib, Health Informatics, and Chowdhury, Business. So the authors from Kuwait who published in the Journal of Advanced Nursing, again reflecting great, I suppose, interest and support from colleagues in different disciplines, but not really a strong footprint emerging from the nursing profession. For the reasons I mentioned earlier on, Ireland has a similar history. It's when the profession develops, when it advances, when it's supported by governmental and university and other agencies, it helps us to do that. So just to have a quick peek at those authors and what they have published in other journals. Workforce, adverse events. These are common topics. Al-Hashim, satisfaction, computerized information. Again, these are a little bit dated as well. Dr. Habib, computerized information system, they work together. And they work together as well. So the affiliations, again, Kuwaiti University, well represented, and the College of Health Sciences. All of these were research articles, all research, every one of them. So, in summary then, the trends in relation to publications from Kuwait, there is clear evidence of scholarly activity in nursing in Kuwait, both in the published literature and in practice. However, publication trends are modest, and nursing scholars need to be encouraged, supported, and assisted to increase dissemination and ensure that nurses and nursing professors are leading and driving nursing research, albeit in a multidisciplinary context. And in essence as well, we are very, we are encouraged to reach out and work alongside, which we are already, our medical, physician, and other interdisciplinary colleagues, the wonderful work that's been displayed this morning, which we're very often working on. Your support with your experience and your track record in the field can be very, very influential in moving the nursing scholastic profession forward. So I would implore that interdisciplinary approach to continue. There's also a need for increased exposure of Kuwaiti nursing scholarship in the high-ranking nursing journals. And although citations, we have to have a proviso, it has a rich contribution to the measurement of scholarship, an important component of building excellence, particularly in the university rankings, there is a potential bias of these databases towards English language journals. And it could have had a negative bias effect on the perception of the footprint of Kuwaiti nursing in these journals. So what are the next steps, colleagues and friends? I think to improve the writing, publication, and dissemination skills. And that is not the academic, intellectual ability of writing. We can write. Everybody is educated at that point. It's the actual skills, tips, and tricks of how to write in a way that clearly contextualizes your work and prepares it for a global market. Increase the rate of editorials. In fact, start writing editorials, as we mentioned. Systematic review, literature review, get those published. Focus on the strengths that you have here. You've access to particular populations, you've novel topics that are being explored in this country, you've interesting insights in relation to culture, religion, family-centered care, and so on. And seek to research where there are gaps. Try not to necessarily repeat what has been done in nursing in other countries simply because. And seek to improve especially your international collaboration. Given the potential volume of research available and the environmental constraints, researchers ought to be strategic in relation to their research priorities. I note in the College of Nursing, Dr. Hannah, Dr. Hennan, etc., Dr. Ali, I mean, there is very large numbers of students and small numbers of faculty. Similarly, in the ICU, nurses who are working in practice, not lots of time for research. So you need to be strategic, work together, get big projects going where you can get a big bang for your buck, and be able to sort of focus in those areas. Try not to dilute yourselves too much because resources are scarce. Large outcome projects need to be focused and prioritized, and you do need leadership by senior nurses in the profession. Final steps, create a strategic vision for nursing and research development in Kuwait, harness ongoing governmental activity that supports capacity building for Kuwaiti nursing with targeted efforts to increase graduates and publications, and this would have a positive impact on the profession globally. Increase research and publication where gaps exist, and additional measures may be required to support Kuwaiti nurses and nursing scholars to publish peer-reviewed publications in high-ranking journals. And this includes understanding the value of national and international projects. Kuwaiti, like the rest of the world, is facing unprecedented demographic workforce and technological challenges for the future. The consistently changing nature of healthcare requires a skilled workforce who can provide evidence-based practice. Nurses are required to understand and use research, and fundamentally, nursing scholars ought to be leading and driving research and evidence-based practice in the field. Like Dr. Ali, Dr. Hanan, Dr. Amna, Dr. Henan, and Dr. Mona, continue to model the way, continue to share this vision and inspire a shared vision, challenge the current process, enable others to act, and encourage the heart. Thank you so much.
Thank you. Thank you, Prof. Timmins, for this talk. So the time has finished, but we can take maybe 2 questions so we can end the session and have you go to the break. Are there any questions? Dr. Fahad?
Good afternoon. Thank you for the excellent talks. My question is for Dr. Ghaffri. One of the challenges that I encounter in the medical education setting is teaching a heterogeneous group of learners. So you have, at one hand, you want to balance not cognitively overloading the novice learners, while at the other time, you don't want to be disengaging the more advanced learners. What are some strategies in your practice that you would advise medical educators?
Yeah, no, we face the same problem. I must say that a few things. I think is that I find 2 strategies. During rounds, as we discussed, is that teach what is needed, and you can even state ahead, is that, so this is for juniors, this is for senior, and often I ask the senior to teach the junior. And I think that's extremely empowering for multiple reasons, is that in my career, when I was asked to teach something, that's when I truly master it. And so during rounds, I asked the fellows to teach the resident. Of course, I editorialize it, but I think that part helped the fellow to not to disengage, and but actually to be involved in those repeated concepts when we need to explain for the next another group of residents where he's driving pressure. For the fellows, so more senior trainees, learning comes in different dedicated opportunities to me. And for example, we identified during the week specific teaching opportunities dedicated for the fellows. So for example, again, we are lucky in our institution, Laurent Brochard works with me in my unit, and once a week he does mechanical validation rounds, where truly is that we raise the level of discussion for the fellows. But it's not easy because again, is that it's multidisciplinary, and as you pointed out, is that they have very different learning needs. But I think use the people that you have because even the trainee, they can be teachers, and they love it usually.
Thank you. Any other questions? Okay. Front row there.
Thank you very much for the excellent lecture. This is for Dr. Fiona. So I just want to ask, we've been trying to promote research for our nurses, but we've been facing a lot of difficulties, especially with their working hours and the longer days that they work, night and days, and all of these shifts as well, which is similar to us. But I find the burden of the work for them is probably more since they are really working at the bedside with the patient. So from your own experience, were you given an allocated time, more time to publish and produce, or how did you navigate through that with your colleagues? Probably did you get help from others also around you?
Thank you, Dr. Zana. Thank you. I know you're very supportive of the nurses in the intensive care as an intensivist, so thank you for your contribution. And a really good question, and we have been challenged in nursing with various recommendations like this. We need to research, we need to be evidence-based, and as you say, you're working in ICU, you're working 40 hours, there is no time to even read the research, never mind perform and conduct the research. So very much in short, what is needed is a strategic approach, a strategy
for example, many of the hospitals now have a dedicated research unit, maybe working with a physician, consultant, maybe an advanced nurse practice or professor, nursing professor, and have a sort of dedicated research unit within that with a postdoc, a research assistant. I know your own team is quite small as well. You just have your postdoc and your research assistant. But infrastructure, time, as you said, and roles of leadership. So, for example, in Ireland, our advanced nurse practitioners now are charged with leading out and conducting research. The nurse in ICU is really only, or the nurse in practice is really only required to read, understand, and use research. So those researching are empowered, equipped, educated, but also given time, as you say, Dr. Zana, given the time, because you do need the dedicated time. Nurses, just finally, can be involved, as you know, in data collection in the large medical physician-led projects. That's another opportunity as well, where they do a smaller amount, but maybe get a contribution if they have been involved in the actual research papers. So that's another opportunity. If you have a very large project like you're working on, and you have nurses involved, you could bring them in, and that would help them as well.
If I may add to your point, I think it's very important that we have an understanding that research is not for everybody. And I think it's one of the strategic things that you have to think about is that early on when you have, and this is not only applies to nurses, but also to medical students and all other healthcare providers, is that early on as they go into the university and they get their early education, having good mentors, spotting on and identifying potential learners who actually would have the skill, have the interest. You can also build on that because understanding each country and us here in the region, and Kuwait in particular, since we are here, there are specific challenges that are specific to Kuwait that could prevent learners from, first of all, knowing that there are, for example, ongoing projects. One of the things we found during COVID, because during COVID there's a lot of online learning and a lot of students who came back from abroad actually hungry, looking for a project. So that was actually a very excellent time to do a lot of research projects. They're there, they have the time. So I think it's important, as she mentioned, having the strategies, but also understanding your local resources, the culture that you have, and then try to come up with the best way of recruiting, because this is something long-term. She showed the data over decades and decades, and this is something we don't want to research for like a couple of years or short-term, but rather than long-term. Any other questions? I would like to thank all of our speakers today. I will invite you to take a photo before you leave. Thank you so much, and we're closing the session.